Super.
So good morning, everybody. Welcome to the first in a series of workshops that Betsy Cadwallader University Health Board are delivering in partnership with Glyndwr University, and thank you to them for their offer and helping us out with this. My name's Sandra Anderson. I am a public engagement officer covering Wrexham and Flintshire, but these workshops will be available to everybody across North Wales. I'd like to introduce Christopher White, who is a lecturer in health. Oh, I've forgotten already. Health and Wellbeing and Mental Health at Glyndwr University. So I am just going to start by asking Chris to start, but also to say if you've got any questions, please pop them in the chat. We will be keeping an eye on them, and Chris will lead us when he wants to ask questions and what we're doing this morning. So thank you again, Chris.
Thanks very much. Okay, so well, firstly, thanks to my colleague Sharon Wheeler, who put a lot of work into this session, but unfortunately has an emergency dentist appointment this morning. So so I was due to deliver content of this anyway, but apologies if I'm slightly rusty on certain elements. I think we'll start out by saying that the session is designed to capture everyone. So if there is someone in the audience there who works quite heavily with data on a day-to-day basis, this might be pitched slightly below or underneath your daily working experiences. So apologies for that, but that's just to give a bit of a brief overview of the kind of things that we've been looking at and reflecting on. So the aims today are to look at how you might find and filter through health information and data, or certainly how we do it and how we recommend that our students do that. Then lastly, how to make sense of it, and then also how to use it and put it into practice. But I'm hoping that it is a fairly interactive session. We would love to hear from yourselves at any point if there's anything you want to add, and tips for each other in terms of how you gather and share your own data. And it'd be really interesting also for us, and in the way in which we communicate with our students on how real life situations pan out. Okay. So there will be comfort breaks as well, and as I said, hopefully this is an accessible and reflective session. So a bit of food for thought. Our current time period has been called the information age, a time in which information has become a commodity that is quickly and widely disseminated and easily available through the use of computer technology. Data is absolutely everywhere, and of course we all became, well, far beyond this group. The majority of people across the country in their living rooms became experts and followers of data as we went through the pandemic, and it's quite clear to see how different media outlets now fight for the role of being the first people to break data and share data. So it's been argued that we live in a world where there's more and more information and less meaning. And it's a really interesting quote. We collect and collect and collect, but don't always look into the analysis. So to reconsider how we work with health information data is an important and perhaps quite a timely exercise. So just to reflect on where does our information actually come from? Again, it's hard to know without being in the field like yourselves, but we are guesstimating based on our own work that you're looking at these kind of areas: mass media, universities, research centres, and then of course your own networks and services. Who are the key players in the dissemination of this data? That's worth reflecting on. Through what formats, and what is the nature? So we may collect data from news articles, reports, journal articles, impact assessments, conferences, but is anyone prepared to share a primary site where they might collect data?
I think for some of us, Chris, we rely on information that comes from Public Health Wales, so their data sources. Also NICE, I tend to go to NICE as well. I don't know what it stands for, but NICE, and I get some research from there. And also there are quite a few articles. And I think the Joseph Rowntree Foundation, they do really good articles, especially around poverty. So for myself, that's where I go to. I don't know about some of my colleagues.
That's really helpful, thanks. Anyone wish to add anything to that? ONS, Office for National Statistics, from Fiona. Yeah, that's great.
WHO.
Yeah.
Stats Wales. Welsh Government as well. Their site has good information links.
Okay, yeah, Stats Wales again there, yeah. And so potentially quite stats heavy then in that case. The other thing that Put It Have Wales as well, yeah. The other thing that I would add really is that from my PhD research, it was based in Greater Manchester, looking at active travel as a public health issue, to cycle and walking to work. And part of that was about interviewing loads of different actors involved in some way in public health. So officers like yourselves, but also many counsellors, public health portfolio holders, CCG leads, directors of public health. And there was, of course, quite a difference in the way in which these different workers interpreted and collected their evidence and the kind of evidence that they placed an emphasis on. So while those heavily involved in more clinical forms of health, of course, it's going to be very stats heavy, and there'll be a lot of academic literature from top medical journals. But as you sift through the workforce, certainly when you get to counsellors who make a lot of health decisions, health policy decisions at least, well, a lot of the evidence that they follow and collect is anecdotal evidence, evidence from their residents, evidence from the people that they hear from the most. So I think that's, worth reflecting on as well. Not only where do you collect your evidence, but where do your partners collect your evidence, and what kind of evidence might they place an emphasis on? Okay, so one important thing to reflect on, and something that we discuss with our students a lot, is the fact that many of our facts are mediated. So in many ways, we are reliant and dependent upon the mass media, but ultimately they are there to sell a product. And the audience desires to be entertained cannot be ignored. So, as I say, we're starting this at the base level. It's quite clear to see that the health stories that we see in the media are those that are going to be headline winning. And as you look into the evidence that goes into them, it's often very weak studies. It's often very limited samples. The correlations that they report are often very, very weak. Now, again, I'm talking to a room that will be very, very aware of that. But as you go through the partners that you may work with, that awareness, or working awareness at least, might not be as strong. The idea is still rife that the mass media simplify and neutrally reflect events and debates that happen out there, but really that isn't the reality. Even if the media is not self-consciously engaged in crusading and muckraking their reporting of certain facts, these facts can be sufficient to generate concern, anxiety, indignation, or panic. So they haven't really looked into too much depth on what they report, but they're happy to report it and share it. And of course, as we see through the terrible things that are going on in Ukraine, there's a real importance to reflect on how things are reported and how neutrally or not things are reported. And we, you know, that isn't just restricted to situations like that. We often see it in terms of health. So a question for you: in what ways do media organisations report information and data to attract audiences, and what are the problems with this?
Shock headlines just to get that initial reaction, and then of course that's not necessarily representative of the wider issue.
Absolutely. Yeah.
And
Yeah, Fiona, you have a hand up?
Yeah, well, just like the lady said before, it's the emotive. They always try to pull on the heartstrings and the emotive, and unless you have that understanding of that subject, perhaps you're not actually able to make a terribly objective opinion of what you're hearing. As you say, everything's filtered, isn't it, for the shock reaction?
Yeah.
Well, that's how I feel anyway about a lot of
Absolutely. Stuff. Yeah. Everything is there with an intent, with a target to bring interest, and the importance placed on the evidence behind it is potentially quite limited. Justine, you had a hand up first.
I did. It's self-fulfilling though, isn't it? The more shock tactics, the more they go for the most shocking information and the panic-inducing information, the more they have to ratchet it up next time. And so it keeps going round and round until we're in a point where it's not fake news, but it's certainly the far extreme of any nugget of information.
Absolutely, yeah, and we'll come on to this point on fake news in a few moments' time. Jenny Ann?
Yes, I get really fed up when you can't find the source of the information, because far too often statistics are bent to fit with the headline, and quite often, particularly in the more populist press, the headline doesn't actually reflect what the article's saying, because the sub-editors are looking for that clickbait to get traffic and to sell papers, rather than to actually give us the real facts. And you know, too often they'll say 50% increase in cancer risk, and then you look and it's gone from 1 to 2 in 1,000.
Yeah, absolutely, yeah. But as you say, those studies are very rarely actually even cited. No, that's really interesting. Anything else that anyone wants to add to that point? Super. Okay. So I think this quote covers really well what we've just been discussing. News reports are brief. They must make their stories hard by using material that seems incontrovertible and not conjectured. Figures are favoured since they have the feel of facts about them, and they add in some graphs, maps, percentages to give this aura of fact. So it's all made to look scientific and it's all made to look solid, but just by putting a number to something doesn't always make it any truer or any more adequate as a source of knowledge. Perhaps the reason we accept statistics uncritically is that we assume that numbers come from experts who know what they're doing, and you know, you could say that that's a fair assumption. But linked to what we were just saying there, we talk to our students a lot about this idea in policy of policy-based evidence and evidence-based policy. Of course, evidence-based policy is the form of policy that everyone would recommend the government go for. They go out and collect some research, they collect their data, they analyse it in a neutral manner, and then they create policies off the back of that. But very often, what they actually find and collect is policy-based evidence, in that they have their ideologies, they know what they would like to implement and do, and then they'll go off and find some evidence and include the evidence that helps support the decision that's already been made. And you could say in many ways that the media do something quite similar. they know what they would like to report and the kind of points that they would like to push through, and they'll jump on any kind of source of evidence that helps them make and support those points. Okay, so another question for you. What does it mean to say statistics are the product of social activity? And that comes from this quote from Best. We sometimes talk about statistics as though they are facts that simply exist, like rocks, completely independent of people. Emma?
I guess just to build on what Jenny Ann said, and to say sometimes statistics can be developed in response to a certain bias. I don't think I can, if I say any more on that, I'll end up confusing myself. But I know what I mean, if that makes sense to you guys.
That's super, thanks. And then I can't quite see all the hands here, but Karina?
Hello. Yeah, I was just going to say there's, you're probably aware, but there's a programme on Radio 4 called More or Less, and it totally deals with the fact that most statistics are lies, and it goes into how they're skewed and things. It's very, very good. And they do a lot about health as well on there.
Super. That's really helpful. Thanks very much. And Jenny Ann?
Yes, I find very often statistics are filtered, and they only use the ones that support their point of view. They ignore the ones that might produce a counter argument where we may need to look deeper to see the real truth. And I was a chemist all my working life, and part of the use of statistics was looking at outliers, which are ones that are outside of the normal statistics, because very often they told you where things didn't quite happen as you predicted. And rather than ignore them, some people just remove outliers because they say, oh, they're just bad data. Very often the bad data gave you the insight. And I think talking about social activity, a lot of statistics from surveys of the public are from those who are interested in being involved. And particularly if it's something controversial, you'll mainly get the people who want to go with a particular point of view rather than surveying a more representative population.
Absolutely, yeah, that's really interesting. It just emphasizes the point, doesn't it, that research is never value neutral. We can discount as many variables as we'd like, but it's never completely value neutral, and that goes for quantitative research as much as it does qualitative research, where of course there is even more human aspects to the research process and the analysis process. I've seen that Sandy's added in the link there for Radio 4 More or Less as well, so thanks for that if anyone wanted to dip into that. So your responses are flowing really well into how the slides start to progress. So we're starting to reflect on really this idea of scientific inquiry, which of course at the core of it is to generate knowledge. And in public health, we use this to understand problems such as risk factors, diseases, effectiveness of programs. But it should be seen as an active and systematic process of inquiry, a tool to explore, describe, understand, explain, predict, evaluate and assess impact. So I think that quite nicely encaptures how research relates to public health as a field. Where can we find this then? So we've already discussed this a little bit. Many of you will collect things from NICE, Public Health Wales. As academic staff, we'll look a lot at something like Google Scholar to collect journal articles. Of course, lots of different charities put out some really nice reports. We use databases a lot again, a lot of the stuff that we do will look at academic journal articles, and of course libraries. Anywhere else that you might dip into in terms of your research? Will a lot of your research be online now? Yeah.
Yeah.
And have any of you experienced any difficulties, challenges in the ways in which your partners work, collect, prioritize evidence, without being too revealing?
Chris, Jenny Ann's got her hand up again, and then I have
Super.
a comment.
Okay, yes, I just wanted to say, firstly, there are sources. I work for a minority community, the transgender community, and we generate an awful lot of our own research because it's almost impossible to disaggregate ourselves as a population from the more general research, because people don't normally collect statistics on sexual orientation or gender identity. But of course, we're very biased because we're collecting information mainly from our own population for what we want. So I'm very aware that although the information is very helpful, sometimes it can be very difficult to use. For instance, one piece of work we did in health said that almost half our population avoids health interaction because of past discrimination or misunderstanding of the needs of the population.
Yeah.
Now, that doesn't mean in reality that only half the population ever gets healthcare from that minority. What it means is there is a high incidence of fear and misunderstanding.
Yeah, yeah. Yeah, I think that's a really interesting point. And Fiona, I'll come to you in a second. A lot of my previous work was based in physical activity, and what you see is a lot of organizations collecting their own data, either because there isn't too much data out there already, or because they want to counter the national measurements or the measurements by which they're funded. And so you see it from a lot of transport groups as well. So the Department for Transport will collect their own data on how many people are active on their commutes, for example, and then local authorities will also go out and collect their own data to try and at least counter or support their own arguments. And so I think there's a lot of course, whenever you attach funding to some kind of measurement, that's always going to be the response. But there's a lot of measuring and counter measuring, which I think is quite an interesting thing to reflect on in terms of best use of time, etc. So Fiona and then Sandy.
Hi, gosh, I'm finding this really fascinating. There was something that came up there that really resonated with me about, we speak to a lot of, I work with people with cancer, I work for a national charity, Macmillan Cancer Support. So obviously my work with engagements is to gather insight. So that's the narrative behind the statistics. And a little bit like Jenny was saying, I could listen to Jenny forever. You speak so well, Jenny. Is the fact that we hear things that aren't going with the statistics that advocacy want to hear. They want to find the people that fit that statistic. And it's not to say the statistic aren't right or wrong, but the narrative is coming up with lots of variables that don't fit that. So trying to get that message through that, well, yeah, that's fine. That's not right or wrong. But there's other things coming out of this. So how we collect that qualitative data to go behind the quantitative. I hope I've got that the right way around. It is Monday morning and I've only had 1.5 coffees. But trying to even internally convince the advocacy teams who are working directly with the government to try and influence policy and change is actually quite, that's a challenge in itself. And having a tool to collect that, to gather the insight and the trends. Well, this is a slow moving exercise, isn't it? It's compared to a lot of the data that comes in, it's quite fast moving. So it's often a bit skewed And sometimes it meets and sometimes it doesn't. But the challenge to get the doesn't, to say, well, actually, that's that, but we need to look at this. This is something else. And just because it doesn't fit the strategy or what Welsh Government want to do or hear or not do or hear, as the case may be, or in our case, it's all the governments, it's all the devolved governments and England. So that's a challenge in itself, because there'll be a cross-cutting theme as well, won't there, that everybody needs to get involved with. Yeah, so it feels like an almighty hurdle for somebody who's just in North Wales and Powys, just talking to people on a screen, really. Where does it all fit into the big picture?
Yeah. Really interesting, really interesting. And Sandy, do you want to?
Yeah, just very quickly, kind of it's an example. It kind of summarises everything that Jenny Ann and Fiona said. Is that recently I was at a launch of some great research, amazing piece of work, but there was a whole section of the community that kind of wasn't represented. And Jenny Ann's nodding her head, and I think Jenny Ann, correct me if I'm wrong, but the answer when we challenged that, the answer was, well, the research isn't out there, the data's not out there. And that was it, rather than saying, well, we couldn't find it, so what we're going to do is we're going to fund finding it. It was a case of it wasn't out there, so we didn't include it. And that kind of highlights that there are, you need to be careful of what you're reading and what's launched out there.
Yeah, I agree with you, Sandy, and I'd just like to say the information is out there. They just hadn't bothered to talk to the populations and say, we can't find this. Do you know where it is? And I think also, just while we're talking about it, Chris, I think it's very important that you look at how you ask the questions to produce the information, because I'm sure we all know you can direct the answers to what you want. And we saw that in one survey recently where they were looking at the effect on a particular population of doing something, and the only people they surveyed were the ones who disagreed with it.
Yeah. No, that's a really good point, isn't it? Yeah, it's not about it's not always about the product and the analysis, but the research tools in the first place. What are your motives for your questions in the first place? Really good point. Emma?
Yeah, a challenge sometimes we have in the local authority is if we have got some statistics or even if it's qualitative research, say it's about a certain community or a community of interest, sometimes members will devalue the research on the basis of the number of people that have responded or participated. And that can be a real challenge, particularly when you're trying to find out something very specific that you might not be able to get from the Public Health Wales data, for example. That's a challenge that we come up against all the time.
I think that's really interesting, and again, it's something I saw in my PhD, that those from strong public health backgrounds, when they were entering rooms with CCGs, directors of public health, they said that they were, even if the question wasn't asked, they were faced with an atmosphere where it was almost, well, have you got a clinical background? And if you haven't, we're simply not going to give this meeting similar attention, I guess, or this evidence that you're presenting similar attention. Does anyone experience anything similar to that?
Yes, I have, in presenting research in health occasions, but that's partly about building up trust. Our group's been working in the area, and particularly we're interested in health engagement, and we found it's taken years and years to get that trust. And it is I found it also in my professional life, because I decided not to do a PhD because I hadn't got doctor in front of my name. In health environments, people would not listen to me. but my colleague who had a doctorate in oceanography was listened to in a health environment.
Yeah, and it's that is a kind of ideology approach that I think will always be there, but it's something to always keep working on. Justine?
I think this is a problem within the third sector as well, in that people have a huge amount of lived experience and knowledge behind their particular expertise, but once they start interacting with both health and local authority, they find they're not treated with equality. And it is very difficult. Jenny Ann's right. It takes years to build up trust. And yet when you look around the third sector, most of us have got backgrounds in health and local authority, and we have huge amounts of experience.
Yeah.
It's not reflective, though.
Yeah. I think stepping back a few points as well, that another strong finding that I found is that the big thing for Greater Manchester was a radical shift towards prevention, supported by a big transformation fund. But many were reporting that the biggest reforms that they saw was in the hospital sector. That's where a lot of the attention still went, and they blame part of that on the fact that for the public in general, the one statistic that everyone is most interested in is A&E waiting times. That's how they perceived it anyway. And you think and you reflect on that, and you think, what a poor measure of health. How long you have to sit to be treated. What a really poor measure of health that is. But it's simplistic, it's easy to report, it hits everyone with a little bit of interest. It's where everyone is guaranteed to have some form of interaction with the health system, and so the media continue to push on it. And of course, the politicians, members, councillors are elected on a 4-year cycle, and so they're interested in short-term data. And I think that's another real difficulty in terms of pushing through qualitative data and looking at more social outcomes of interventions and programs, is that they're perhaps a lot more difficult to demonstrate, both in terms of longevity, but then also it's very difficult, as everyone here will be aware, to demonstrate lives saved or lives extended. But I find it really interesting that we seem to measure health on the basis of ill health.
Yeah, can I just jump in
Please do.
and give you a real example of that? There was a scare went around a few years back from some really stupid headlines about trans people didn't live past 30 because of all the problems with suicide and substance abuse, drug taking, alcohol abuse, eating disorders, all sorts of stuff that are higher in the LGBT community. And a group of young people came to me at a meeting and said, Jenny Ann, is it true we won't live past 30? And I said, well, I'm over 70. So that rather knocks that one on the head. And when I went and looked at it, it was a complete abuse of statistics.
Yeah.
But if public health had looked at that and thought, oh, wow, we now need to put loads of money into this minority community, which would have been great, but would have been disproportionate.
Sure. That's really interesting. Okay, I'll just finish this slide and then we'll go on a short comfort break, if that's okay. So just in terms of a few top tips based on this early section, and of course a summary. So we've looked at the fact that there are various types of information data in the health sector, and that information is produced by people and organisations. We often look at data as though they are rock solid facts, but they are produced by people, and there will always be some form of bias. They're of course reported by people. It's important to remember then that all information is a product of social activity, which does raise questions about the quality of the information and the agenda behind it. Scientific inquiry through research generates knowledge that we can use in the sector in many ways, not just the hard science, factual, medical research ways. And so it's vital to work with health information data responsively, considering the privacy, accuracy, property and accessibility of information, commonly referred to by the acronym PAPA. Okay, so if we take, oh, hi Sharon, Sharon's just joined us as well, just as we're about to pop off on a break. If we just go on a 5-minute comfort break and join back on, I'll just shut my camera off and join back on at 11:15. Is that all right? Super. Thanks everyone, and thanks for your contributions.